Go for more Medicare risk adjustment diagnoses as one of the best ways to improve risk adjustment factor scores. Lesson objective of Module 2. As a healthcare provider, you will learn the different opportunities for new Medicare risk adjustment diagnoses. We will cover the following topics. The use of the clinical to find new Medicare risk adjustment diagnoses. The use of the paraclinical to find new Medicare risk adjustment diagnoses. Most common Medicare risk adjustment diagnoses seen in imaging tests. The science of pathophysiology seeks to provide an understanding of the mechanisms of disease and explain how and why alterations in body structure and function lead to the signs and symptoms of a disease. Understanding pathophysiology empowers healthcare professionals with the knowledge of how and why disease develops. By using your physiopathology knowledge, you will be able to find a new MRA diagnosis as the consequence or the effect of the current one. If one of your patients has severe chronic obstructive pulmonary disease, what other MRA diagnosis could have resulted from this condition? We know that chronic obstructive pulmonary disease is one of the diffuse hypoxic pulmonary diseases. Therefore, it will cause hypoxemia that results in pulmonary vasoconstriction and then pulmonary hypertension, a risk adjustment diagnosis that belongs to a different HCC. That is why all patients with severe chronic obstructive pulmonary disease will need an echocardiogram to assess pulmonary hypertension. If one of your patients has chronic kidney disease stage 4 or stage 5 or end-stage renal disease, what different HCC diagnosis could result from the kidney disease? Alterations in calcium, phosphate, and vitamin D metabolism begin when the glomerular filtration rate or GFR decreases to 25% or less. Hypocalcemia is accelerated by impaired renal synthesis of 1,25-dihydroxyvitamin D3 with decreased intestinal absorption of calcium. Renal phosphate excretion also decreases, and the increased serum phosphate binds calcium, further contributing to hypocalcemia. Acidosis also contributes to a negative calcium balance. Decreased serum calcium level stimulates parathyroid hormone secretion leading to hyperparathyroidism. That is why it is essential to order PTH intact and serum calcium level for patients with CKD stage 4 or greater to assess secondary renal hyperparathyroidism, a risk adjustment diagnosis that belongs to a different HCC. When your patient, hospitalized for acute CVA or stroke, came after discharge to see you for a post-hospital follow-up visit, do not document acute CVA in your notes since it is a hospital setting diagnosis requiring emergency care. Instead, document, if present, the residual deficits, the late effects, or sequelae, such as hemiplegia or hemiparesis, a unilateral paralysis or neurological weakness usually associated with stroke. Keep in mind ICD-10-CM equates plegia with paresis. That is why for coding purposes, neurological deficit such as paraparesis, hemiparesis, and quadriparesis is classified as a complete paralysis, paraplegia, hemiplegia, and quadriplegia, respectively. Many healthcare providers are hesitant to assign a quadriplegia code if the patient is not paralyzed, missing the opportunity to report the severity of the patient condition adequately. Remember that you must use plegia codes implying paralysis to report the weakness of one or more extremities clearly associated with a stroke. Differentiate neurological quadriplegia from functional quadriplegia. Functional quadriplegia is a term used in ICD-10-CM to identify patients with complete immobility due to severe physical disability as seen in severe contractures, rheumatoid arthritis, or patients with extreme frailty due to severe physical deconditioning as seen in severe dementia. Always document a disease with its greatest level of complication. This is what we learn from the Module 1 lesson. Therefore you need to avoid reporting diabetic without complication when a diagnosis is documented and can be associated with diabetes mellitus as a complication. If a diabetic patient tests positive for microalbuminuria consistently at least for 3 months, note the duration in the record and report the condition as persistent. Doing so establishes microalbuminuria as an early diabetic renal complication rather than a simple clinical finding of proteinuria. Consider documenting diabetic nephropathy when no other cause can explain the proteinuria. In kidney disease, kidney filtration can be impaired. This can be due to underlying chronic conditions like diabetes, HTN, etc. The glomerular filtration rate is the benchmark in diagnosing and managing chronic kidney disease, which is defined as a reduced function present for greater than 3 months. Consider documenting diabetic chronic kidney disease with the CKD stage when no other cause can explain the low glomerular filtration rate. Diabetes puts people at higher risk for cardiovascular disease. It often leads to serious problems in the feet through the development of nerve damage or poor circulation. Weak or absent pulses in the lower legs may indicate developing the peripheral arterial disease. Consider documenting diabetic peripheral angiopathy when no other cause can explain the weak pedal pulses. Diabetic neuropathy is the most common complication of diabetes. The underlying pathologic mechanism includes metabolic and vascular factors related to chronic hyperglycemia with ischemia and demyelination contributing to neural changes and delayed conduction. Both somatic and peripheral nerve cells show diffuse or focal damage, resulting in polyneuropathy. Consider documenting diabetic peripheral neuropathy when no other cause can explain the numbness and tingling. Gastroparesis is delayed gastric emptying in the absence of mechanical gastric outlet obstruction. It is most commonly associated with diabetes mellitus or surgical vagotomy. Diabetic gastroparesis represents a form of neuropathy involving the vagus nerve. Symptoms include nausea, vomiting, abdominal pain, and postprandial fullness or bloating. Consider documenting diabetic gastroparesis when no other cause can explain the decreased GI motility. A cataract is a cloudy or opaque area in the ocular lens. Cataracts develop because of alterations of metabolism and transport of nutrients within the lens. Although the most common form of cataract is degenerative, cataracts also may occur congenitally or as a result of infection, diabetes mellitus, radiation, trauma, or drugs. Consider documenting diabetic cataract when no other cause can explain the cataract. Patients with diabetes often develop ulcers of the lower extremities for many reasons. Advanced calcification process of arteries of the legs. Loss of protective sensation allowing the patient to continue to ambulate despite an injury to the foot. Consider documenting diabetic ulcer of lower extremity when no other cause can explain the foot ulcer. If the patient is a known diabetic and the blood sugar measured on the service date is high, document diabetes with hyperglycemia rather than uncontrolled diabetes, since uncontrolled diabetes is an unspecified diagnosis with two different meanings. Diabetes with hypoglycemia and diabetes with hyperglycemia. Therefore, to avoid confusion, we need to be specific by documenting diabetes with hyperglycemia. Protein energy malnutrition, described by Mech Manual as protein energy undernutrition, is common in the institutionalized elderly and patients with conditions that decrease appetite or impair nutrient digestion, absorption, or metabolism. It is often seen in conditions affecting gastrointestinal function, conditions increasing metabolic disease, conditions described as wasting disease. The malnutrition's high-risk conditions seen in the charts are HIV/AIDS, cancer, dementia, end-stage renal disease, severe chronic obstructive pulmonary disease. But malnutrition is often not documented by healthcare providers who are evaluating patients with these more serious conditions. To support malnutrition as a diagnosis, it requires a thorough evaluation of the patient's circumstances, dietary intake, pattern and rapidity of weight loss, an assessment of muscle and fat loss, not just a simple reporting based solely on the BMI. Keep in mind that your patient can have malnutrition with a normal or elevated BMI. Besides malnutrition, other MRA diagnoses can be the result of cancer or the consequence of the cancer treatment. Cancer can weaken the immune system by spreading into the bone marrow and preventing bone marrow from making so many blood cells. Certain cancer treatments can temporarily weaken the immune system. This is because they can cause a drop in the number of white blood cells made in the bone marrow. Cancer treatments that are more likely to weaken the immune system are chemotherapy, targeted cancer drugs, radiotherapy, high dose of steroids. MRA immune disorders include antineoplastic chemotherapy-induced pancytopenia, a granulocytosis secondary to cancer chemotherapy, drug-induced pancytopenia. Peripheral neuropathy is among the unexpected side effects of cancer treatment. It is caused by damage to peripheral nerves, resulting from many different factors, including some chemotherapy drugs using vinca alkaloids, platinum compounds, taxanes, and thalidomide. Tumors themselves can cause nerve damage as well if they grow close to and press on the nerve. Risk adjustment neuropathies in patients with cancer include drug-induced polyneuropathy, critical illness polyneuropathy, radiation-induced polyneuropathy. Very high doses of chemotherapy or radiation therapy to treat certain cancers can destroy patients' stem cells. To restore their blood-forming stem cells, these patients need stem cell transplants. Therefore, there are new risk adjustment diagnoses to be documented such as bone marrow transplant status, stem cells transplant status. If any surgical procedure was performed to create an artificial opening or ostomy, report the status of the patient, gastrostomy status, ileostomy status, colostomy status, cystostomy status. What about a patient with obesity? Usually, we document morbid obesity when the patient has a BMI of 40 or greater. There are provisions for a patient with a BMI between 35 and 39 to be diagnosed with morbid obesity if the patient has comorbidities associated with obesity. However, the comorbidities must be named and must be linked to obesity. For example, Dr. John documents his notes as follow. Patient is seen today for follow-up of obesity, hypertension and hyperlipidemia. His BMI was 36. And here is Dr. Steve's documentation. Patient is seen today for follow-up of obesity with hypertension and hyperlipidemia. His BMI was 36. Dr. Steve's documentation supports morbid obesity since he notes clearly the link between obesity and hypertension, by using the word with as the link. Most frequent documented comorbidities are hypertension, hyperlipidemia, rheumatoid arthritis, diabetes, anemia, chronic kidney disease, depression, chronic obstructive pulmonary disease, hypothyroidism, osteoarthritis, gout, ischemic heart disease, lung disease.